This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2023, all rights reserved. My name is Lexie Caraway. I am a registered respiratory therapist at Carl Richland Memorial Hospital in Albany, Illinois. I also serve as delegate and PACT co-chair for the Illinois Society for Respiratory Care. Welcome to today's program, Factors Associated with Accidental Decannulation in Tracheostomized Children. Upon completion of this AARC webcast, participants will be able to discuss the purpose of an article review, identify how to review a journal article, identify study design, review study methodology, discuss implications from journal article as reviewed by authors, editors, and our review. I am pleased to welcome Denise Pepper Lauderbaugh. Denise, a respiratory therapist of 25 years, is a clinical practice specialist at Rady Children's Hospital in San Diego. Denise graduated as a fellow from the Evidence-Based Practice Nursing Consortium in San Diego, holds a bachelor's in respiratory management, a bachelor's in advanced respiratory concepts, and a master's degree in public health. She has served as the primary investigator in multiple evidence-based practice, quality, and research projects, has presented her research across the country, has authored multiple abstracts and manuscripts, and was the ARCF winner for 2 of her projects in 2020, and is also a speaker at interdisciplinary conferences. Neither Denise nor I have any relationships to disclose. Brand names of products and/or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of a specific product, but merely illustrate a point of emphasis and to provide information and education regarding the availability. Denise, welcome to the program.
Hello, thank you for that introduction, Lexie. I am very excited to be here today and appreciate being asked by the AARC to review this article for the February JournalCast. Today, we will be reviewing the Editor's Choice journal article, Factors Associated with Accidental Decannulation in Tracheostomized Children by Gregory Villarreal et al. I wanted to quickly look at the objectives of this course so that you will have an idea of how the course will progress. So Lexie already reviewed these, but this is how the course will progress. So why do we need to do a journal article review? If the article is already in a peer-reviewed journal, isn't that enough to say that it is quality evidence? It actually is not. The purpose of an article review is to critically evaluate material that's already been published so that we can identify and summarize and evaluate the information that the authors have presented to us to find out its strengths and its weaknesses and its findings. Critical appraisal of the literature allows us to judge both its worthiness, its validity, its reliability, its value, and its relevance in a particular context. The validity of the research refers to the quality of the research methods used or how good of a job the researchers did conducting the study. The reliability of research means similar outcomes can be achieved when the care techniques of a study are replicated by other clinicians. We do this through article reviews by systematically appraising and assimilating the scientific evidence from journal articles. So we should utilize a structured list to review journal articles that allows us to systematically evaluate the article in an evidence-based approach. A structured, systematic approach allows proper critique and appraisal of the research while utilizing an evidence-based approach to the literature review. Article reviews allow us to apply knowledge of our study designs and statistical methods to the appraisal of clinical studies, and other information, reviewing the diagnostic and therapeutic effectiveness by referencing the results of the article. Article reviews also allow us to stay abreast of the new knowledge. It increases our knowledge regarding the advances in biomedical, clinical, and subspecialty areas. When reviewing journal articles, we start with looking at the authors, finding the funding, or looking at their funding resources, the study objectives, the purposes, and the quality of evidence. So first, let's look at the authors of the study. We want to know if the authors are credible. Do they work in the field that they are discussing in the article? Can they be considered content experts? The authors of this article are an interdisciplinary group of physical therapists and doctors. Gregory Villarreal is the primary author of the article. Mr. Villarreal works as a physical therapist with a background in kinesiology, and he also works in clinical epidemiology in Chile. He has over 39 published articles, which he had published between 2012 and 2022, so 10 years of experience, most on breathing, mechanical ventilation, tracheostomy, and rehabilitation. Patricio Baranio, the co-author of this article, has been the primary author of many articles and conference papers on tracheostomized patients and mechanical ventilation also since 2012. So Gregory Villarreal and Patricio Baranio do work in the field they are discussing in the article, and I would say they can be considered content experts. All of the other co-authors have relatively few manuscripts as co-authors only, and all of the authors are from Chile. The authors note no financial support as the funding sources. For study objectives and purposes, the study's purpose was to characterize a retrospective decannulation events to determine any factors associated with accidental decannulation in tracheostomized pediatric subjects in a long-term mechanically ventilated acute care facility in Chile, so a LTAC. So you'll see on the slide there is a quality of evidence pyramid, and we use quality of evidence pyramids to assess quality of evidence. So we're going to talk a little bit more about the evidence pyramids. There are a variety of evidence pyramids available to assess the level of evidence of scientific literature. I prefer to utilize this one in the photo for my review, which utilized filtered information as the top of the pyramid. An evidence-based medicine pyramid is a simple diagram that was created to help us understand the different levels of evidence so that we can get a perspective on the study's strengths and weaknesses in relationships to other studies. Filtered information has been reviewed and critically appraised by a team of people who are qualified to review the topic and then who agree on the information provided. At the top of the unfiltered information is randomized control trials, which is our gold standard for doing research. This article was a case-controlled retrospective study, so it is on the lower end of the pyramid. Retrospective studies are observational studies and can only show a correlation between factors and not causation. So further studies would need to be done to prove that the factors the authors identified are actually a cause of accidental decannulation. Now, this doesn't mean that their data is not good data, as it is a design study and it did have specific controls. The factors found to correlate with accidental decannulation in the pediatric population in their long-term care facility can be utilized in further studies and quality improvement projects to make a difference. So next in our review, we move on to the background of the study. So let's look at the aim of the study. The aim of the study is to characterize accidental decannulation events and to determine what factors are associated with these events in tracheostomized pediatric patients in the LTAC. And then, is the research question relevant? And absolutely yes. Accidental tracheostomy decannulation is a fairly frequent complication of tracheostomy and mechanically ventilated patients in pediatrics. Accidental decannulation is an emergency for patients, especially in patients with new tracheostomy placement. It can lead to pneumomediastinum, pneumopericardium, pneumoperitoneum, pneumothorax, and generalized surgical emphysema. Unplanned tracheostomy decannulation is frequently associated with an increase in morbidity and mortality in the inpatient setting, and anything we can know about potential risk factors may help us prevent decannulation. So what is already known about this subject? Accidental decannulation is a common complication of tracheostomy and is also commonly identified as a cause of death associated with tracheostomy use in patients of all ages. According to the authors of this paper, there is limited research regarding the risks of accidental decannulation in pediatrics. And the American Thoracic Society describes this in the 2000 American Journal of Respiratory Critical Care Medicine as well. There is some information in an article from Alexander White et al. 2012 on adults by which they consider change of shift, no limb restraints, mental status change, and increased airway secretions as the highest risk factors that they found associated with accidental decannulation in adults within a long-term acute care facility. Legowski et al. In 2017 agreed that tracheostomy in children is associated with higher rates of complications than tracheostomy in adults, and that the mortality rate associated with a tracheostomy is higher in children than in adults. However, most pediatric deaths are more associated with the underlying disease of the patient than with the actual tracheostomy or decannulation. A new article by Winnings et al. In 2022 found that accidental decannulations occurred in a prospective cohort of pediatric inpatients in nearly 5 events per 1,000 tracheostomy days, with most resulting in minimal harm. Most common causes of accidental decannulation in that study included 32% by patient movement and 27% during tracheostomy care. So then the last question and background, was there any concern about conflicts of interest? And the authors did not identify any concerns about conflicts of interest. So the most important component of a critical appraisal is the evaluation of the appropriateness of the research article in order to assess the usefulness and the validity of the research findings. The research methodology is the specific procedure or the techniques used to select and analyze the information about a topic. Research methodology follows specific scientific principles. The methodology section should answer 2 main questions. How was the data collected or generated, and how was it analyzed? So this was a blinded, case-controlled, retrospective experimental study that compared a group of participants possessing a very similar condition to a group lacking that condition. Here, the participants possessing the attribute of the study are called the case, and those without it are called the control. It is important to remember that the case group is chosen because they already possess the attribute of interest. The point of the control group is to facilitate the investigation. So studying whether the case group systematically exhibits the attribute more than the control group does. So since this was a case-controlled retrospective study, the results are correlational and not causational. Case-controlled studies are always retrospective due to the nature of the study. A case-controlled method is used so specific outcomes or diseases can be matched with an appropriate group of controls without the outcome or disease selected. So it was appropriate in this study. The strengths of this type, move my slide forward. The strengths of this type of study include that it can be completed relatively easily and cheaply with fewer subjects needed. And in this study, the authors blinded the data collectors so that they did not know which group the subjects they were collecting belonged to, whether the case or control. Limitations to this type of study are reliance on recall of staff or on the records documentation because it was retrospective, and confounders that could change the outcome, and finding a control group that is similar can be difficult. If the researchers utilize too many similarities to match the case to the controls, there is a limitation in finding enough controls if you overmatch. So there is the potential for recall, selection, and reporting bias in the study. Knowing this, let's see how the authors selected their control group. So the researchers chose a blinded case control study. For this study, the physiotherapists who collected data from the clinical records, were also known as observers, were blinded to whether the subject was allocated to the case or control group of the study. Blinding in a study is done to prevent observer bias. Observer bias means that some researchers will have expectations regarding the outcomes, and blinding is a strategy to minimize this form of bias. This is a strength of the study. A case-controlled study is used so a certain outcome or disease can be matched with an appropriate group of controls without the outcome or disease selected. In this case, tracheostomized children who had an accidental decannulation are the case study, and the controls are tracheostomized children without accidental decannulation. They had to use careful consideration to choose appropriate controls, considering the same types of diseases, ages, the reasons for the tracheostomy, and the need for mechanical ventilation. This study was completed at a single-center, long-term rehab facility for children with prolonged mechanical ventilation in Chile, so the outcomes of this similar study may be different if it was in a multi-center or critical care hospital setting or in another country. The inclusion criteria for this study were children hospitalized with tracheostomy at Josefina Martinez Hospital between 2013 and 2018. Each child with accidental tracheostomy decannulation during that time frame was included in the case group. Control groups were recruited from children at Josefina Martinez Hospital between 2013 and 2018 who did not experience an accidental decannulation. For each case study patient, 2 control subjects were randomly selected from the group without decannulation. Controls were randomly matched to case subjects by age group, either less than 24 months or greater than 24 months at the accidental decannulation date. The exclusion criteria was any accidental decannulation due to tracheostomy material failure. There were no exclusions during the study. The total sample size was 123 subjects. The number of subjects enrolled were 41 in the case group and 82 in the control group. Utilizing a larger sample size in the control group aided in determining the average value of the quality of the tested samples, ensuring that there was a more precise mean and identifying the outliers more easily. The sample size is directly related to the statistics margin of error, or how accurate a statistic can be calculated to be. The larger the sample size is directly related to the statistics margin of error, or how accurate a statistic can be calculated to be. The larger the sample size, the smaller the margin of error. For the purpose of sample size and adding power to the study, 2 controls were enrolled for each case. There was no indication in the manuscript that a power analysis was performed prior to the enrollment, but the enrollment of 2 controls for each case that increased the power of the study indicates that there may have been. There are threats to the internal validity of this study in participant selection, but the researchers randomly assigned the control groups to mitigate this. Reporting bias also affects the study. There may be differences between reported and unreported accidental decannulations in both the case and control groups due to the retrospective nature of the study, relying on documented harm. Confounding bias may also play a role if the researcher failed to identify confounding variables or exposures that occurred when the variable was not accounted for that may have a relationship with both the exposure and the outcome. So, for example, if some of the subjects had tons of thick secretions from around the tracheostomy and the nurse added extra pieces of gauze under the trach to absorb the secretions so the gauze would last longer, and it made the trach higher, this would be a confounding variable not accounted for in the study, which could significantly impact the outcome. Ethical concerns. There are usually minimal ethical concerns with a retrospective study, but I would have wanted to see a mention of how they kept the data, where it was stored and secured to ensure the data was de-identified and is considered anonymous. There was a mention that the study was approved by the Ethics Committee of Santiago, Chile. The suitability of the statistics methods used and their subsequent interpretation are part of the critical appraisal of an article. In this statistical analysis slide, we will quickly review the information provided by the authors in their statistical review of the data. In further slides, while looking at the data, we will look more into some of the values. I just want to mention that I am not a statistician, and I always use a statistician in my research. I do have knowledge of the statistical terms, tests, and analysis, but I will always defer to others who are more knowledgeable than I in this area. So please feel free to help me at the end of the PowerPoint if I have not presented something in the correct light. Continuous variables were reported as mean and standard deviation or medium and interquartile range according to the Shapiro-Wilk test for normality. The Shapiro-Wilk test examines if a variable is normally distributed in a population and is most appropriate for small samples. The Wilcoxon rank sum test was used to compare the medians between 2 populations, and the t-test was used to measure the difference in group means divided by the pooled standard error of the 2 groups as appropriate. The nominal and ordinal variables are described as frequency and percentages. The comparisons between case controls were done with chi-squared. A chi-squared test is used to help determine if the observed results are in line with what we expected and to rule out that observations are due to chance. A chi-squared test is approved for this when the data being analyzed are from a random sample and when the variable in question is a categorical variable. The Fisher exact tests were used for categorical variables. The Fisher's exact test was used to determine whether or not there was a significant association between 2 categorical variables. It is typically used as an alternative to the chi-squared test of independence when 1 or more of the cell counts in the 2x2 table is less than 5. And the magnitude and direction of effect between the factors of interest and the accidental decannulations was determined by conditional logistic regression model. Accidental decannulation risk was established by odds ratio with a confidence interval of 95%. A p-value of less than 0.05 was considered statistically significant. This means that there was a 99.95% chance that it did not happen by chance. Data was analyzed with a Stata 13 in College Station, Texas. The main results of the study found by the authors is that accidental decannulations occurred during hours of reduced supervision, when the patients were in a sitting position with the ability to reach their hands midline, and when they had smaller tracheostomy tubes, less than or equal to 4.0 millimeters inner diameter. So now we're going to dig into the study. In Table 1, we see that the case and control groups are very similar demographically, with no statistically significant differences regarding age, sex, weight, or height. The three statistically significant clinical variables in the table that correlated with accidental decannulation are the internal diameter of the tracheostomy tube, not being on mechanical ventilation 24 hours a day, and reduced supervision by nursing staff. Also similar in the number of cuffed tubes, brands of tracheostomy tubes, and need for prolonged mechanical ventilation. Although there was not statistically significant differences in age, weight, or height, the case group were all slightly older, slightly bigger, while the internal diameter of their tracheostomy tubes was smaller, indicating a smaller tracheostomy tube with a shorter length in a bigger patient. This could be indicative of an airway issue that was not collected, or of weaning off mechanical ventilation, which was not collected. I would have liked to have seen the length of the tracheostomy tube listed in Table 1 to get a better idea of the part that it plays in unplanned decannulation. Mechanical ventilation used for 24 hours a day was higher in the control group than in the case group as well, which may have indicated weaning in the case group. This led to a statistically significant p-value in the group who were not mechanically ventilated 24 hours a day. In Table 2, items of note are more patients with neuromuscular, central nervous system, and genetic diseases in the control group, and more patients with airway obstruction, Down syndrome, and bronchopulmonary dysplasia in the case group. In Table 1, the authors noted airway obstruction in 12 patients in the case group and 9 in the control group, for a total of 21. In Table 2 categories and primary diagnosis, only 6 patients are listed with airway obstruction, and 4 out of the 6, or 67%, are in the unplanned decannulation group. These patients are listed as 3 with subglottic stenosis and 1 with laryngomalacia. Patients with subglottic stenosis and or reconstructive surgery may require tracheostomy tubes that are smaller and shorter that would be unusually small considered for their patient size. This may be a confounding factor that was not accounted for that should have been considered if Table 2 is accurate. Table 3 is a crude comparison of the developmental milestones between the case and the control groups using univariate analysis. The univariate analysis explores each variable in a data set separately. It does not have to consider other variables and does not show a relationship between cause and effect. A univariate analysis can provide misleading information if there are more variables involved than can affect the outcome. The main objective of the univariate analysis is to describe the data to find patterns by looking at the mean, mode, deviation, and dispersion. It looks at the range of values and the central tendency. It describes the pattern of the response of the variable. In Table 3, we find a pattern of subjects in the prone position, sitting, standing, with hands together, at midline and supine, rolling to the side, rolling from the back, and hands together at midline in the sitting position, were statistically significant with a p-value of less than 0.05. In the univariate analysis of the milestones, the odds ratio is expressed as OR. Odds ratios are used more commonly in case-controlled studies. An odds ratio is a measure of the association between an exposure and an outcome. In this example, the first odds ratio would be the relationship between supine positioning and accidental decannulation. An odds ratio equal to 1 shows that the exposure did not affect the outcome. An odds ratio greater than 1 shows that the exposure is associated with higher odds of the outcome, or that the developmental milestone is probably associated with accidental decannulation. An odds ratio of less than 1 is associated with lower odds of the outcome, or that the developmental milestone is probably not associated with accidental decannulation. When reviewing Table 3, we note that prone, sitting, and standing have an odds ratio greater than 1, as well as independent moving of the subjects. The movements with high odds ratios greater than 4 are prone, sitting, standing, rolling to the side, rolling from front to back, hands together at midline in sitting position, and pulling to stand. But don't just look at the odds ratio without looking at the confidence interval. A confidence interval refers to the percentage of probability or certainty that the confidence interval would contain the true population parameter when you draw a random sample many times. A large confidence interval indicates a low level of precision of the odds ratio, and a small confidence interval indicates a higher precision of the odds ratio. The narrower the confidence interval, the more confident we are that it contains the population parameter. The confidence interval, however, does not measure the statistical significance. In this table, the confidence interval is 95%, which means that we are sure in 95 out of 100 cases that the parameter is contained. So looking at Table 3, we need to review the p-value and the odds ratios for statistical significance. A p-value of greater than 0.05 and an OR greater than 1 has us looking at a lot of the table. In Table 3, prone positioning, sitting, rolling from front to back, and hands together at midline in a sitting position were all statistically significant with p-values less than 0.05 and odds ratios greater than 6. The odds ratios and lowest p-values were hands together while midline in the sitting position, but it was not the only value that was statistically significant in the study. From the results, it would seem that once the kids were on the move, we need someone watching them. So keep in mind when reviewing this table that this is a univariate analysis looking at one variable at a time and not comparing the variables to each other, which variable is more likely a factor of decannulation. Table 4 reviews the variables by total number and percentages of subjects who had accidental decannulation. The variable includes weekdays and weekends, time of occurrence, day or night, number of accidental decannulations per hour, mechanical ventilation use at accidental decannulation, and mechanism of accidental decannulation. It would have been good for the authors to include patients on mechanical ventilation for 24 hours a day in this group, as we did see a difference between the case and control groups, with 84% of the control group using mechanical ventilation 24 hours a day, and only 56% in the case group using mechanical ventilation 24 hours a day, with a p-value of 0.01. This may suggest that more subjects in the case group were actively weaning off of mechanical ventilation, which might be considered a possible factor associated with accidental decannulation. Over 29% of the accidental decannulations were related to loose trach holders and changing of the trach holder. Providing additional education on the securement of a tracheostomy tube during holder changes and proper securement of the holder and scheduled checks for securement may decrease a substantial number of accidental decannulations in this group. So now we're going to look at the editorial that was written. Dr. Awad and Dr. Berlinski provided the editorial entitled Accidental Decannulation in Tracheostomized Children, in the Respiratory Care Journal. Dr. Belinsky disclosed relationships with a few companies, none of which would impact his ability to make an unbiased review of the accidental decannulations. In their introduction, they note that there is a higher risk for morbidity and mortality for patients less than 1 year of age. They noted that 63% of the subjects who had accidental decannulations in the study were receiving mechanical ventilation, which is consistent with other literature. The editors noted that the developmental milestones of bringing hands to midline occurs around 3 months, and sitting unsupported occurs around 6 months, both of which are in the under 1 year description identified in the literature for accidental decannulations. The editors suggested that close monitoring of when patients reach these milestones should be utilized, and increased staffing ratios should be considered when those milestones are met. The editors also suggested that staffing ratios are the one thing that could be adjusted to minimize accidental decannulations, where the size of the tracheostomy tube cannot. The editors also suggested that the lack of mortality in the study is due to a combination of skillful staff, which is identified by the main authors, and tolerance of the patients to being disconnected. As noted in Table 1, the mean age of the patients in the case group was 2 months older than the control group, and the patients were 0.7 pounds heavier on average in the case group, yet the internal diameter of the case group trach was less than or equal to 4.0 in 83% of the cases, despite the older age and larger size, which we previously discussed. This may imply that these patients were in the process of weaning in the case group, and thus they were more able to tolerate the accidental decannulation. Dr. Awad and Dr. Berlinski described the biggest limitation of this study as the retrospective design and the inability to calculate the incidence of accidental decannulation, because accidental decannulation events are described as the rate of events per hour instead of per 1,000 tracheostomy days that we traditionally use as a comparison in other studies. The editors concluded that as the number of children with tracheostomies grow, adequate staffing and technological advances will be needed to limit the complications. So first, before considering use of this data, you have to consider if this information will benefit your patients. Are your patients similar to the pediatric tracheostomized patients in an LTAC in Chile? Overall, in our structured review of this journal article, we found that this was a retrospective, case-controlled study, not high on the evidence pyramid. 2 of the authors are considered subject matter experts in the field with no known bias. It was a blinded study, and protocols were in place to randomize the subjects and to minimize the bias. The authors succeeded in answering their research question. While the information from this article is evidence, and we did find some factors with statistical significance, it cannot be said that these factors are the cause of the accidental decannulations. We did find their methodology to be valid. So what do these findings mean? After reviewing the findings, we find that the tracheostomy size, internal diameter less than 4.0 millimeters, and supervision by staff are statistically significant at a p-value of 0.01, which means both of these correlate with accidental decannulation. By our review of Table 4, independent movement of the subjects as well as prone positioning seem to have a higher risk of accidental decannulation, and not only hands together at midline in sitting position. Because this is a retrospective case control study, we can only accept that these findings correlate with accidental decannulation, and that's not actually a cause. This study was completed in an LTAC for children in Chile, so we would need to do further research to assess this as a potential risk factor in a multi-centered study or acute care center before we could decide if this would be something in our centers. No previous research has reviewed the subject's ability to independently move as a possible risk factor for accidental decannulation, so this is new data for us. Although Winnings et al. In 2022 previously published data showing that the majority of accidental decannulations were due to self-manipulation and behavioral factors, which is consistent with this research. So how should these findings impact practice? We could consider increasing the sample size by adding more years or doing a multi-center research. An increase in the sample size will make the confidence interval narrower and give us a more precise idea of if that data correlates with the outcome. More research needs to be completed with a closer review of the reason for the smaller tracheostomy tubes. Future research in accidental decannulation should include the ability to reach midline while sitting and the ability of the patient to move independently as potential risk factors for accidental decannulation. Future studies should consider the size of the tracheostomy compared to the size of the patient as a potential risk factor for accidental decannulation. Increasing nursing to respiratory staffing when the patient has a tracheostomy tube that is smaller and shorter than the trach would be usually for their size age, and when they can reach for the trach and move around, makes sense to decrease accidental decannulations. But also having a sitter in the room may be a cheaper and more practical application than nursing ratios in this young population. So the authors concluded that the ability to reach the midline in a sitting position, the use of a smaller tracheostomy tube less than or equal to 4.0 millimeters of inner diameter, and the small nursing staff subjects ratio are factors associated with a higher risk of accidental decannulation in tracheostomized children in an LTAC. Accidental decannulation in tracheostomized children occurred mainly because of the subject's self-manipulation and during hours with less healthcare team supervision, such as at shift changes and lunchtime. The authors strongly recommend attention to these factors to avoid accidental decannulation and its potential harmful consequences. The editors concluded that closely monitoring developmental milestones and making appropriate personal adjustments could help. They felt that additionally, checking trach tube holder, ties, and ventilator connections could decrease the risk for accidental decannulation. Per the editors, and in my opinion, changing the size of the tracheostomy tube is not an option due to the need for mechanical ventilation. And our conclusions, more research needs to be concluded. That future research should include the ability of the patient to move around and developmental milestones. And we should be increasing nursing and respiratory staffing when the patient has a trach that is smaller and shorter than it would normally be for their size and age, when they can move around, and that having a sitter might be cheaper. The relevance of this research to your own practice is the final critical appraisal of the article. And then Lexie will move to questions.
Thank you, Denise, for all that information today. I have a few questions here for you. You mentioned the sample size as far as maybe increasing the size. What do you think would be an appropriate size of sampling for both, total, or how would you split it with the case and control?
So I think they'd have to add a couple more years because they didn't have enough. They didn't have enough case patients, and you can't match more than 2 controls to a case. Then they didn't have enough case patients, so I think they'd have to add a couple more years and get maybe like 20 more case patients enrolled. I'm not a statistician, so that would be a statistical analysis that they'd have to do to find out exactly how many people they'd have to enroll.
Okay, great. I have a question here. Is there any connection of accidental decannulation related to Velcro-only closures? Comment then is, at our facility, we added a 1/4-inch twill string interwoven into the Velcro-only items and eliminated these incidents so far. I mean, could that be an easy change, and would that make a big difference?
I'm not sure I understood the question. Is this a question between Velcro and twill ties, or?
Let's see. Basically, Velcro only versus Velcro adding twill string.
The only comparison that I've ever seen in the research is comparing like a twill versus the Velcro holders. I've never seen a combination study done, so I can't answer that question.
Okay.
That would be good research, though.
Denise, you work in a large hospital, in a pediatric children's hospital. Is this a kind of study? I mean, is this something you would be looking to study yourself? Is this something you would even be interested in looking at?
Yes, actually it is. After I saw this, I thought, this would be really interesting to do. We already gather this data. So, yeah, it would be really helpful. And I think a lot of people gather this data. We gather it with all of our unplanned extubation data. So I think a lot of children's hospitals are gathering it. So maybe we could get a multi-center.
Yeah, and so potentially you could do a retrospective study on this with in combination with other centers then.
Yes.
All right. And I think you already kind of touched on this, but what would you change about this study? If this was going to be your study, how would you change it yourself?
I would definitely look at that. I would look at the size of the like a comparison, like the size of the tracheostomy to the size of the patient, maybe as a ratio. I'd have to talk to a statistician and to the pulmonologist and the ENT about that, like how to exactly compare that. But I would look at that because I think, I mean, obviously the length of the tube in the patient, if it's too short for the patient, it's going to come out really easy. And that's going to be a factor that we would know, or do we just know that that's a factor, and so that we remove that from the study? I don't know. But
and that would potentially have something to do with but diagnosis also, you mentioned.
Yes. Well, it could have diagnosis or weaning. You know, we put in smaller trachs as we wean our patients.
Thank you.
And so a lot of those patients were coming off the vent because they weren't on 24 hours a day.
Good point. Thank you. I have a question here. So this says, from a RT case management perspective, who would or could pay for a bedside sitter? Would it be the patient's family, the hospital, or the patient's insurance company? I have an opinion about this, but I would like to see what you would say, Denise.
Our hospital pays for sitters if the patient's had more than has pulled out their own trach. Once they pull out their trach, we pay for a sitter.
Mm-hmm. I think that's probably the case in most situations, but I would definitely be interested in hearing about others.
If we can show in the future that there is a number of risk factors based on research, like they have a certain score, and they're at risk, then that would be great. Maybe we could provide a reason why we have to pay for a sitter.
Is there a score that you do that requires a sitter? Is there some sort of safety screening that you're doing?
Not yet, but if we could come up with risk factors and we could say this patient has this number of risk factors.
What would you think about a study? It's a very, very good point, Denise. What would you think about a study like this, similar to this, comparing adults, sort of apples to oranges, but, you know, with the times and, you know, whether they had a sitter or not, or, you know, just whether they're weaning or not, the things that kind of come up in this one, in this study, do you think they would be very similar?
I think the changes in nursing times, like understaffed times would be similar. I think in adults, loose ties would be, and changing of during changes would be frequent. But I think a lot of times, I don't know, adults, I haven't worked adults in 20, I don't know, oh my God, it's been 30 years now. In 30 years, they used to cough them out. That's what I remember. They have such strong coughs. So if your trach ties weren't tight, they would just cough them out.
Mm-hmm. There's a lot of research indicating that very similar information that, you know, these things happen during shift change and with poor staffing ratios and things like that. So like I said, it's not exactly the same patient population, but I think it definitely could be, there's some correlation there, I would imagine. Okay, well, Denise, thank you again for joining us today, and thanks to all who attended today's webinar. Please join us for our next broadcast on March 8th for a presentation by David Wheeler on breathing life into the patient encounter, creating a meaningful, evidence-based patient experience. And on March 17th, our next JournalCast will be presented by Christopher Picciuto and moderated by Robert Joyner Jr. Thank you again and have a great day.
Thank you, everyone. We'd like to thank our speakers for sharing their excellent presentation, and thank you also to our participants for joining us today. If you're a group participant, please have your group leader submit your information to the Group Attendance tab to be followed up with follow-up instructions on how to submit for credit. If you have any questions, please email crce@aarc.org. This concludes today's presentation. Once marked concluded, the system will automatically submit credit for you after you complete the survey. You can check your status in the Credit Submission tab. We hope you all have a great afternoon.